I will go ahead and get us started, and we'll watch for more people coming in as we go along. Welcome to the third session in the webinar series on genetic services in Appalachia. And we ask that you mute your microphone for the talk and place any comments or questions in the chat box while our speakers are talking, and there will be time afterwards for discussion. We ask that you not record our session. We will be recording the session and providing a transcript on our webinar website. And we're happy for you to go back and listen to anything that you might have missed. So if you missed any of the earlier sessions, they are available. So we're happy to have your engagement with that. We also have some evaluations. If you haven't completed those previously, we would be happy to have you complete the evaluations on the previous sessions just to give us feedback, and also for our funders. And as you may be aware, this series has been funded the AHRQ, the Agency for Healthcare Research and Quality, and they have enabled us to provide this session for free, and also allowed us to bring in some great speakers from around Appalachia and that are doing work in the Appalachian area.
Team Kimmel 8. Attention please, pediatric response team Kimmel 8.
Sorry.
Attention please.
There's just a warning playing on my end. Disregard that.
So hopefully Shannon's building isn't burning down, and well, because that would be terrible. Yeah, so as you know, our aims include to develop a research agenda for genetic services in rural Appalachia in particular. And each month, we will be having and have had speakers who are working in genetic service provision in medically underserved populations with a focus on setting a research agenda for rural Appalachia. And again, we will request your feedback at the end and hopefully be able to get some more information from you. So I would now like to introduce you to our speakers, Ms. Shannon Detweiler and Ms. Julia Stone. And Shannon received her Master's of Science in Genetic Counseling from the University of Michigan in 2016. She has 5 years of clinical experience and previously worked for the Cancer Genetics Program at Michigan Medicine and University of Pittsburgh Medical Center. And so that's how we became involved. And Shannon has been one of the folks who was very early in this process as we were trying to figure out how to best address service provision in Appalachia. So we appreciate her continuing engagement.
Happy to be involved.
We recently transitioned to a research-focused position at New York University's Langone Pancreatic Cancer Center. And I'm hoping I said that right. Is it Langone?
Yes.
Okay. Julia Stone will also be speaking, and I believe that they've planned their discussion that they will each trade off throughout the session. So I'll go ahead and introduce her as well. Julia Stone received her Master's of Science in Genetic Counseling from the University of Pittsburgh Graduate School of Public Health in 2018. She has 3 years of clinical experience in prenatal, cancer, and adult genetics programs through the University of Pittsburgh Medical Center. Julia recently came to the UPMC Clinical Genomics Laboratory, where she is primarily involved with the workflows for hereditary cancer gene panels and whole exome sequencing. So with that, we are very happy to have you join us, and I will turn it over to Shannon.
Thank you. And should I share my screen with the slides, or are we having you advance the slides on your end?
I would be happy for you to share.
Sure. Okay. Let me get that pulled up then. All right. Oops. Okay. Hmm. All right. So just to begin, we'll be talking today about genetic services in Appalachian, Pennsylvania. Neither Julia nor I have any disclosures or conflicts of interest. And as Dr. Kelly also mentioned, I am no longer with UPMC, but Julia is. And we also had these slides reviewed by other counselors who are present at UPMC.
Hey. Just the mailman.
All right.
Yeah, that's definitely what I was going to say.
1800 London.
Don't be rude.
Your microphone. Thank you.
Yes, thank you. All right. Julia, could you review this slide, please?
Sure, yeah. So we wanted to, right off the beginning, give a brief overview of some of the primary service delivery models that are utilized for genetic services in the city of Pittsburgh. Our discussion today is really going to revolve around how the clinics work and how the process works for genetic counselors at McGee Women's Hospital in Pittsburgh, but a lot of these models are also used by the other genetics providers within the city. So there's three main primary service delivery models that we utilize at this time. The first one, the classic service delivery model, are in-person visits where patients actually come to the hospital and get to meet one-on-one with a genetic counselor. Sometimes those appointments involve a physician, oftentimes they do not. The second type of service delivery model is a telemedicine model. This was something that we utilized prior to the COVID-19 pandemic. And what we had established, what was set up was patients could go to UPMC facilities at other hospitals that were not UPMC McGee Women's Hospital. And they would be set up with a video to connect them to a genetic counselor in Pittsburgh. And we're going to go through a little bit about some of the sites that we work with that do telemedicine. But the key thing to note with the telemedicine programs are that the clients still have to go to a facility. They just don't have to make the trip into Pittsburgh. So they might be able to have access to a facility closer to their home. And then the third type of service delivery model are video visits. And this sounds very similar to telemedicine. They are often used somewhat interchangeably, but for our purposes, we do consider them two separate things. Video visits were something that have become temporarily available to the genetic counseling team due to the COVID-19 pandemic. This allows us to meet with patients directly through a video app. Basically, they're able to sign onto an app on a phone or a tablet through their My UPMC, and we are able to sign in and communicate with them via the medical record service. So it's confidential, it's HIPAA approved, and that allows us to meet with our clients from the comfort of their own home. They don't have to go to a separate facility for their genetic counseling services.
Right. All right. The next thing that we wanted to review is where are genetic counseling services available? So given that Julia will be kind of talking about prenatal and I'll be talking about cancer, we thought it would be useful to show that there's some overlap between the places where both of these things are available. The primary place where both services are available in person is at UPMC McGee Women's Hospital. And we also have some shared telemedicine sites. And again, telemedicine denoting that it's a facility where a patient goes and meets with a nurse in person. Cancer Genetics has some additional telemedicine sites, and we also have two other in-person locations. So Hillman Cancer Center, specifically in Shadyside, is a place where genetic counseling services are also available. And once per month, a counselor staffs a clinic at UPMC Passavant in Cranberry, which is northwest of the city. Okay.
And then for the prenatal genetics team, most of those appointments right now are seen either in person or via video visit. Actually, there are some telemedicine sites and contracts that we do still have established. However, those services largely stopped after the onset of the pandemic and being able to do video visits, because understandably clients would prefer to, if they have the option, potentially meet with their counselor from home. Of note, these video visits, they were slated to go away. They are part of, I believe, the emergency COVID provision here in the state. So it was something that was supposed to go away in September. That has been extended. So we are still able to provide these video visit services at least through March 30th of 2022. And we're still waiting to see whether or not that'll be something that we can continue beyond that time. So we also wanted to take a moment to highlight some of the other genetic services that are available in the city of Pittsburgh. We're not going to go through each one of these in detail, and neither Shannon nor I have been intimately involved with either of these clinics. But we did want to let everybody know, although we're going to be primarily focusing on the cancer and prenatal service delivery models and services here in the city, there's a whole host of other genetic services. The two big ones that I want to highlight that I think are really unique, we have an ophthalmology genetics clinic, so a group of genetic counselors that meets with both children and adults for evaluation and discussion about inherited eye diseases. That's not a common clinic. A couple of years ago, I think there were only tens of counselors, maybe 40, that were practicing ophthalmology genetic services in the country. I'm sure that's gone up since then. That's something unique here. And then we also have a physician who's doing, a physician and a team of genetic counselors that are incorporating genetic services into a primary care type clinic. So they call it a primary care precision medicine clinic. And I'm really interested in seeing where that clinic continues to go and what comes out of it, because I think that's a really interesting practice in how to incorporate genetic services into a day-to-day primary care facility. The one thing that you may notice is not on this list that was included in my introduction is an adult genetics clinic. That unfortunately is a clinic that does no longer, or at least for the time being, we do not have a clinic in the city of Pittsburgh that can accommodate adult patients for general genetic services outside of the specialty services listed on the slide and cancer genetics and prenatal, of course. That is a significant limitation of genetics in the city at this point. And frankly, with genetic clinics all over the country and throughout Appalachia, I'm sure. It's something that that we're working to hopefully get back at some point, but for right now, we do not have that service here in the city.
We also just thought that it would be helpful to show a map that kind of connects to the Venn diagrams that we showed earlier. So the services provided by UPMC are unsurprisingly concentrated around Western Pennsylvania, although we do get quite a lot of coverage of like all of Western Pennsylvania from north to south with our different satellite clinics. The stars just indicate that there are places where both prenatal and cancer services are available, mostly telemedicine. And then there are a couple of areas where cancer genetics telemedicine services are available as well. One thing that is noteworthy is that while we certainly see a lot of people from like Altoona, Johnstown, and over, we are also the closest cancer genetics service and potentially the closest prenatal service, definitely cancer, for people in Eastern Ohio, Northern West Virginia, and sometimes even upstate New York. I routinely saw patients that were sort of within this halo around the border of Pennsylvania. If you're not close to something like Cleveland or New York City or something like that, we did get patients that would drive quite a distance to sometimes even be at one of our satellite clinics, let alone at Pittsburgh. So the catchment area that the clinic serves is quite a bit larger than the Pittsburgh metro area alone.
So some of the reasons why somebody may be referred for a prenatal or preconception genetics consult, and I make a point to emphasize we in the prenatal clinic will see patients both who are pregnant and patients and couples who are considering a pregnancy but aren't pregnant at that time. So both during a pregnancy and before. We'll see anybody essentially who has a higher chance to have a pregnancy with a genetic or inherited disorder, or anybody who wants to learn more about what their chances might be and what testing options might be available. So some common indications include parental age. As parents get older, there might be an increased risk to have a child with certain genetic conditions. Any personal or family history of a genetic disorder or things in the personal or family history that somebody might be curious as to the chances for them to have a child with something similar. So for example, birth differences, intellectual disability, autism, developmental delays, etc. Anybody who's a carrier of a genetic condition, whether that was identified through routine carrier screening during pregnancy, or if it's something that they know about from prior to a pregnancy or from a prior pregnancy. Anybody with a high risk aneuploidy screen result. So somebody who's pregnant, who's had some sort of blood work completed that's indicated an increased chance for their child to have a chromosome difference. They'll come and meet with us and we'll talk about what those chances might be and some potential options for next steps. As well as ultrasound differences. We know many things on ultrasound are sporadic or multifactorial, so related to a combination of both genes and non-genetic factors. But occasionally genetic differences can be related to an underlying, ultrasound differences can be related to an underlying genetic predisposition or disorder. One of the things I wanted to highlight here was actually our fetal diagnosis and treatment centers. So this is a group that helps manage pregnancies, typically with complex or significant ultrasound, structural ultrasound differences that require extra monitoring during the pregnancy. So things such as heart defects, congenital diaphragmatic hernia, ventriculomegaly, etc., that really require a team effort for management. If a genetic counselor meets with a client and the indication is because of a structural ultrasound difference, we'll make sure that those patients are looped in to the fetal diagnosis and treatment centers for their pregnancy management. The routine pregnancy management still goes through their obstetrics provider, but the imaging and coordination of those imaging consults, neonatology consults, they help come up with a birth plan with the patient and the family. So we'll make sure to get patients looped in through there. And then on the flip side, anybody who's referred to the fetal diagnosis and treatment centers. If they had an ultrasound difference identified at their home ultrasound department and were referred to this center for further evaluation and continuation of care, the first stop is to meet with a genetic counselor. We're involved with that clinic in two different ways, but very intimately so. And actually one of the coordinators for that clinic is a genetic counselor herself. And then a couple of other indications, anybody with a history of infertility or recurrent pregnancy loss, sometimes that can be related to a chromosome or other genetic reason, and anybody who wants a more in-depth discussion about testing and screening options that are available before and during a pregnancy.
And then to go to my area of specialty with cancer genetics. So one thing to explain structurally about the way that the UPMC cancer genetics clinics are set up is that there is one clinic that primarily sees gastrointestinal cancers, so colon cancers, pancreatic cancers, et cetera. And then the other clinic is primarily breast and ovarian cancer, but really serves as everything other than GI. It's just sort of that breast and ovarian are some of the most common indications. So with that preface, the cancer genetics program sees patients with either a personal or family history of cancer in some sort of way that is concerning for a hereditary predisposition. So that can include things like early onset breast cancer, defined as any breast cancer diagnosed under 45, colon cancer, typically diagnosed under 50, renal cancer, often anything diagnosed 46 or under, endometrial cancer under 50. Melanoma is something that has a strong environmental component, but if you have an early diagnosis or multiple melanomas, we can also see that. I will also say that there are combinations of those types of cancer that even if it's not necessarily early onset, if you see multiple individuals with breast, colon, renal cancers, things like that in a family, or even more than one diagnosis in a person themselves, that can also be a reason to come to cancer genetics. Ovarian or pancreatic cancer at any age should automatically warrant a referral to genetics. We saw quite a lot of those individuals having a prostate cancer that has either metastasized or that is aggressive, as denoted by a Gleason score on pathology of 7 or higher, should also be referred. There are also certain endocrine tumors or cancers that warrant a referral to genetics. This is not a particularly common reason for referral, but we would see people that had things like paragangliomas or pheochromocytomas. Early onset primary hyperparathyroidism is also a fairly common indication. As something that I alluded to earlier is if an individual themselves has multiple diagnoses of cancer or multiple cancers in the same side of the family, there are certain combinations of cancer diagnoses at certain ages that can warrant a referral as well. And we would often see individuals who were coming in because a relative of theirs had had genetic testing previously and had a mutation or pathogenic variant identified, and that individual was coming in for consideration of single site testing or testing for the known mutation in the family. We would also, if we found individuals who had a mutation on a panel test, would try to facilitate single site testing for their relatives. We get a lot of referrals from a number of different physicians. So the wait list for cancer genetics was often like 4 to 6 months out. So awareness of the availability of cancer genetics was not really like a problem. So a lot of the referrals that we get are from gynecologists, from breast surgeons. That's probably one of the main sources for the kind of regular cancer genetics clinic. There is a specialty clinic called the BCSCC breast cancer. Oh gosh, I'm gonna forget what the S is about. Essentially, it is a clinic for any woman diagnosed with breast cancer under 50, even though I can't recall the acronym perfectly at this time. And there is a counselor who's on call every week, seeing patients on an urgent basis. And many of the new breast cancer diagnoses are referred by breast surgeons. We would get some referrals from primary care physicians. There were a number of people that were savvy enough to, ask family history questions and recognize that certain patterns of things should warrant a referral. There were also some dermatologists, urologists, and gastroenterologists that either were knowledgeable and would refer to us. And oftentimes these people we had kind of a symbiotic relationship with them, where there were certain providers that we would refer people to for screening if they were found to have a condition or if they were still considered to be at an increased risk for cancer. And then we would sort of get referrals from them because of their increased awareness of what to do with these patients that did have some sort of need based on a hereditary cancer predisposition. Okay. Oh, this is quite small and unlabeled. I'm not sure what happened to this slide. My apologies. There was a better version that had some labels on it. Essentially, I was able to get some numbers from the cancer genetics clinic that were current as of about January or February of this year. That's the last time that the numbers were pulled. The graph on the left side is supposed to indicate the total number of patients that have been seen by the cancer genetics program since 2018. So roughly 1,500 patients were seen back in 2018, and that had increased to about 1,661 patients as of 2021. And one note that was supposed to be included on this chart was that that number is probably an underestimate, and the rate of growth probably would have been even higher had it not been for the pandemic and a lot of cancellations in the early days before the video visits were available and routinely used. The smaller chart off to the right is specific to the urgent patients that are seen. So once per week, there is a genetic counselor who is on call, and their patient volume can be quite high. So most counselors see full-time counselors in the cancer genetics program see about 10 patients per week. You can have up to about 20 patient slots on an on-call week. It usually doesn't go quite that high, but I routinely saw like 12, 15 patients. A lot of brand new breast cancer diagnoses for people that need genetic testing in order to inform their surgical decision-making. But we would also see other people like women with ovarian cancer who were considering initiation of a PARP inhibitor. So this is another thing where I think the trend would have gone up even higher over time. It started out in 2018 with 423 patients. And then I think the actual trend would probably continue to peak beyond that 530. One problem here is that when patients have video visits, there's no way to mark them as being urgent versus non-urgent. So there's almost certainly an additional block that should be added to that last column of video visit patients that were urgent, whereas this one only captures in-person urgent. So that alone makes up a pretty substantial portion of the patients that are seen, just to give you an idea.
I can tag on to that and say we weren't able to obtain those numbers for the prenatal preconception genetics clinic, but I can say that each of the full-time counselors in that clinic see anywhere between 15 and 20 patients a week on average, so a little bit more than cancer genetics. And the team size in 2018, 2019, 2020 was around the same, pretty similar. And so I expect those numbers to be approximately this, pretty similar.
Mm-hmm.
So when a client or a patient is referred to a genetic counselor for a prenatal or preconception indication, there's a lot of things that we do with that individual or things that we can do with that individual. Primarily, the genetic counselors provide a comprehensive reproductive risk assessment, including a family history assessment. So in every single appointment, we're taking a detailed family health history for at least immediate family members to see if there might be anything in the family that could impact a current or future pregnancy. And then, of course, we take into account anything else related to that particular pregnancy. So any test results that have already been obtained, or screening results, any ultrasounds that have taken place, etc. We provide pre-test genetic counseling about reproductive genetic testing and screening options. And that includes a comprehensive discussion about the benefits, risks, and limitations of these options. Our goal is to make sure that the person in front of us has a solid understanding of exactly what the testing and the screening options can and cannot do, what their purpose is, and what the benefits and also what some of the risks could be, right? We can potentially find things that could impact other family members or that can increase patient anxiety. And pregnancy is already a really stressful time for a lot of people. And so we recognize that these screening options aren't for everybody. And our goal is to make sure that that the patient in front of us has the information that they need to make the most informed decision about how they would like to utilize that testing or screening, if at all. And many of the people that we meet with after having a discussion decide that no, these testing and screening options really aren't for them at that point in their care. If somebody does decide to proceed with a test or a screen, we do coordinate that. And I've been using testing and screening pretty vaguely, but I did provide a list of some of the types of tests and screens that we do help coordinate. So aneuploidy screening, it's routine blood work to help assess if a pregnancy may have a higher chance for a chromosome difference, primarily a handful of trisomies, and potentially some microdeletion disorders, although that's still very new. Routine carrier screening, we talk about routine options versus broader options, looking at more conditions. Parental karyotyping, looking at the chromosomes of the parents, as well as prenatal diagnostic testing. So during a pregnancy, patients have opportunities potentially to pursue prenatal diagnostic testing through either chorionic villus sampling between 11 and 13 weeks of pregnancy, or amniocentesis anytime at or after 16 weeks. And so we help schedule those procedures. We're able to actually put them on the books and work with our scheduling team, and coordinate all of the testing that may be involved for those kinds of procedures. We also have the capacity to help coordinate umbilical cord blood testing at the time of delivery. So sometimes parents may want additional genetic information, but are understandably uncomfortable with doing a prenatal diagnostic procedure. Those procedures do come with some risk. With every pregnancy, there is some chance that those procedures could lead to a complication that could result in a loss of that pregnancy, either a miscarriage or preterm labor, depending on when it's performed. And so some individuals and couples elect to defer testing until after delivery. And if that testing is going to have impact on their baby's neonatal care, then we can help coordinate, and we work really closely with our neonatologists to help coordinate genetic testing on the umbilical cord blood. A lot of times that looks like routine karyotype analysis, but that can also include molecular diagnostic procedures. After all the testing is complete, then we also do the post-test counseling. So we receive those results, we interpret those results along with the physician group that the genetic counselors work with. We'll interpret those results and then share those results with the patient. Oftentimes we've set up some sort of plan for how those results are going to be delivered. Most of our results we deliver by phone, and patients are generally comfortable with that, but we do give the option if they prefer to come into the hospital or to set up a video visit for a results disclosure. We can make referrals to appropriate providers. So some of the common referrals that we're making are referrals to maternal fetal medicine, as well as to the fetal diagnosis and treatment centers, and neonatology, things like that. We often sometimes make referrals if somebody has a child, maybe who has a previous child who has a history of something that could require a genetic evaluation. We'll make referrals to our children's hospital for that child, because that could potentially have impacts for the current pregnancy. One of the big things with FDTC that I realized I glossed over earlier is we do also have an in utero fetal repair team. And so we have performed recently over the course of the past 3 to 5 years, we've had some successful in utero spina bifida repairs that you can read about online. And all for those types of surgeries, those patients need to have one of the requirements is that they do have a prenatal diagnostic procedure, and that there have been a normal karyotype and microarray analysis. And so the genetic counselors are actually involved in coordinating some of those early steps to qualify somebody for a procedure like that. And we're making sure that if we're meeting with somebody, who has a baby with a spina bifida, for example, that we're referring them to the physician and the team to talk about in utero repair options. And then through all of this, I've talked a bit about how this can lead to patient anxiety and stress. We provide a lot of psychosocial support for our clients throughout the process from start to finish. We try to spend a lot of time working with them to make sure that they're getting the right test at the right time, they're understanding the results, and that they feel supported as they are going through this process. For some of our clients, they do utilize the results of genetic testing to make decisions about whether or not to continue a pregnancy. That is a discussion that we have with our clients, as much or as little as they would like. And if they are considering going down the path for a potential abortion procedure, then that's something that we do talk about, and we make sure that they have the phone number for our family planning team. But we recognize that that's a sensitive discussion for a lot of couples. It's definitely not something that all couples elect to do, but it's something that we can help support patients in if that's a path that they choose to take.
And switching over to cancer genetics again. So really, between the two different clinics that I mentioned earlier, we're able to offer services for genetic counseling and germline genetic testing for a broad spectrum of cancer predisposition syndromes. This was just a brief note, again, mentioning the types of clinics that are available. The first step for patients is pre-test genetic counseling and psychosocial support. So what sessions typically look like are, going through the personal and family history, highlighting what conditions, if any, are the most likely to be a potential explanation for the family history of cancer, and also acknowledging that it's possible that there might not be a genetic explanation. We talk through the different possibilities of genetic testing outcomes and coordinate the test. For in-person visits, that's almost always a blood draw. For the sort of traditional telemedicine visits, it's also typically a blood draw. Part of the benefit of having a nurse involved at the facility on the other end is that we have a person there to help sign the consent form and to take the patient for the blood at the visit. Video visits are, as I'm sure we're not the only people who have experienced this, it's a little more challenging to either get the patient to go to a blood draw or to get a saliva kit and send it back. A lot of people adapted to that with the pandemic, but there is a little bit of an extra step involved there in terms of getting the sample. And one thing that we often do, either at the time of the visit or very shortly after the patient has decided to proceed with testing, is to provide an estimate of cost. So I think a lot of the genetic counselors in the call will be familiar with the patient anxiety associated with the potential cost of cancer genetic testing. There is still this sort of memory that's been either present in patients or passed down through families that testing used to be very expensive. So in order to kind of provide that information and to reduce at least one part of the anxiety, we are able to get cost estimates ahead of time. We often send a test result out. There are different labs that are contracted with various insurances. So depending on what type of coverage a patient has, that'll dictate where their sample goes, although we do have in-house testing for the lab that Julia currently works for. And then when we get those results back, again, the majority of results are disclosed via phone. And one of the strengths of the clinic is really interpreting the genetic testing results in the context of the family history. So most of our test results are negative, which is just generally how cancer genetics works, but we utilize a number of different risk models, especially for estimation of breast cancer risks. And even if a person doesn't have a genetic mutation found, if their risk is high enough, we sometimes still refer them to other clinics. So there is the breast and ovarian cancer detection and early detection and prevention clinic, which is run by the same medical director as the cancer genetics program. And that is a clinic where women go if they're estimated to have an increased breast cancer risk just on the basis of family history alone, but in the absence of a genetic mutation, or if a woman has a genetic mutation that puts her at an increased breast cancer risk, but is not yet affected. So that's one of the bullet points under, if indicated, referrals to appropriate providers. If a person has a mutation in a gene that is associated with other cancer risks, I feel like we have a really robust network of providers that we can refer people to. And that kind of alludes to the symbiotic relationship I mentioned before, that often the people that refer us are also people that we know are knowledgeable and are able to provide the types of screening that our patients need, like particular types of colonoscopies, particular types of EUS. There are certain gynecological oncologists that we refer women to discuss things like preventative salpingo oophorectomies or hysterectomies. So if a person has a need to have a discussion to reduce their cancer risks, then we had a pretty good idea of where to send them. A lot of the specialists are concentrated around Pittsburgh, but even further out in areas like Erie and Altoona, we had identified providers that were good resources for our patients. And then one other thing I mentioned before is that we do help to coordinate testing for at-risk relatives. Julia actually used to staff a single site clinic that we had once per month. So another thing that people may be aware of is that many genetic testing companies, if you have a positive result identified on a panel, it opens this window of testing for your patients that can range from 90 days to sometimes up to 6 months. Some companies really extended it during the pandemic. And in a clinic where we're already scheduling out 4 to 6 months, when you suddenly have all these people that need to be seen for a free testing window, especially if it's a mutation other than BRCA1 and 2, which typically does not have insurance coverage, that puts some strain on your clinic. but we were able to adapt and to open the single site clinic that required, a copy of the testing report ahead of time so that we could help to accommodate those patients who were at, 50, 25% risk for a recently identified mutation in one of their relatives.
I can add on to that. That single site clinic has continued. So there are some other counselors that are helping to staff it now. It didn't stop with my transition.
Yep. Right. And then this is just an overview of who do we have that's providing services. So Julie, if you wanted to take over the prenatal part first.
Yeah, I don't know that we have to go through this in too much detail, but essentially we have one physician who oversees all of the genetic counselors and about 7 genetic counselors working in prenatal and preconception genetics. Some of these counselors work part-time in the clinic and do part-time with some other clinics or more managerial things, and some of the counselors are full-time.
Similarly, in cancer genetics, we have 1 medical director. There are also 9 genetic counselors now. So there were a couple of growth positions very recently to help address the wait times and just the fact that the clinic has expanded to cover so much ground over time. I've also indicated that the last 2 counselors on that list specifically staff the gastrointestinal clinic, which is a separate but related entity to the cancer genetics program. And then I highlighted 2 of the nurses that are in main support at the Altoona telemedicine and Hammett clinic in Erie, respectively. I also wanted to note at the bottom, just for logistics, that we do have administrative support from genetic counseling assistants. When I left, we had 1, but I know there were efforts to hire a second. Julia, can you comment on how much support we have?
2 2 full-time genetic counseling assistants and 1 part-time who is one of the current genetic counseling students.
Yep. And then we have 2 schedulers as well. So a lot of the tasks of dealing with insurance, packaging up samples, fielding patient calls, getting family histories. We get a lot of support from our genetic counseling assistants in that regard. So really focusing more on the counseling as a counselor.
So this is an overview of how billing for genetic counseling services and compensation for our services work at McGee Women's Hospital. I do want to emphasize that this is very specific to our hospital and our institution. It does not necessarily apply to other institutions in Pittsburgh or other clinics in Pennsylvania. But here at McGee, genetic counselors are not able to bill independently for our services. We are not credentialed with insurance companies, so we cannot bill independently. So all of our consults actually have an authorizing physician who reviews our notes and our orders and signs off on everything. There is a CPT code that's available for billing for genetic counseling services, 96040. That code actually can only be billed, from my understanding, if a genetic counselor is billing under their own name, which we cannot do here at McGee because we're not credentialed. So what happens is in the system, we do tracker charges. That 96040 code is a time-related code. So it's per 30 minutes of service. Anything under 45 minutes is considered 30. Anything over 45 minutes is considered 60. And that would continue to, if you're going over a 60-minute time, although that's pretty uncommon. Most cancer appointments are typically about 60 minutes, and the prenatal appointments are typically anywhere between 30 to 60 minutes, depending on the indication. So what we do is in our medical record system, we use Epic. The genetic counselor does indicate a charge. It's tracked under 96040 for every 30 minutes of time, but that charge on the back end is actually converted into a facility fee. So we are billing a facility fee. We're not billing for our services under a genetic counselor name. With the COVID-19 emergency declaration that is allowing us to perform these video visits, it is also allowing us to bill for the video visits in the same way that we bill for an in-person consultation. So it's treating those services as if the patient was coming to the hospital.
I will say that I have seen this model used in other places. We can't specify, but we thought it would be useful to say this is something that's done at McGee. It's a model for how genetic counseling can be provided in other places. And this varies from state to state based on licensure laws. So just wanted to add that real quick.
And for any genetic counselors who are on the call today and who may not know, the National Society for Genetic Counseling has an excellent resources on credentialing and billing and coding for genetics and genetic services on their website. I actually use that as a bit of a resource when putting together these slides as well.
For those traditional telemedicine sites that we mentioned earlier, there are contracts in place for specific sites that are listed here. So the billing works similarly. There is a facility fee. The institution bills for our services, and then a fee is received on that end. So it's a similar but somewhat different service just because of the telemedicine aspect of that. For all other telemedicine sites, our medical director, who is able to bill under her own name, unlike a genetic counselor, bills for her services. So just referencing between this slide and the map earlier, you can kind of get a sense of how billing works at different places.
And for the contract-based sites, actually, it is a contract. I don't think it's dependent on time. We don't actually input a time. We don't input separate 30-minute charges for those consults. So it truly is a contract between the two institutions for those services.
Yep.
So quickly, we can highlight some of our community outreach activities. I want to make sure that there's time for questions. This is definitely an area of improvement, I would say, for both departments. The prenatal genetics team, they do educational visits with local providers' offices every year, primarily obstetrics providers' offices, as well as our reproductive endocrinology team. We work very closely with them. They would be the ones seeing patients who might be going through in vitro fertilization or utilizing assisted reproductive technologies. So a lot of it is geared towards education for local providers. We do also, we field students from the local genetic counseling program. We field and work with nurse practitioners, medical students, anybody who might be spending a day or so observing with our genetic counseling team. But otherwise, there isn't as much by way of community outreach. I think that's definitely an area for improvement for that team, area of opportunity.
Similarly, in cancer genetics, there are, through the different counselors that staff the clinic, efforts to reach out to the community several times per year. Some of the different organizations include FORCE, so BRCA carriers, the National Ovarian Cancer Coalition, a survivorship workshop hosted by McGee Women's Hospital, and then a virtual education series through the Women's Cancer Center. I have a personal interest in presentations and education, so I gave quite a few talks during my time at UPMC, but I will concur with Julia that most of the outreach that we did was to medical providers. So I often gave talks to things like nurses, different oncologists during tumor board, some of the surgical fellows and residents, and different like gynecology groups. And I think that there is a hope that perhaps educating the providers who make the referrals, that there's sort of like a trickle down education. But there's certainly additional community outreach that could be done. And then to address Dr. Fall's question, yes, 9 genetic counselors for cancer. And the schedulers and the GCAs share scheduling responsibilities. So effectively, there's sort of like 4.5 people that can help with that.
And the hereditary GI clinic also has their own scheduling.
Correct. I forgot about that. Yep. Okay. We also just wanted to include a little bit of information on different challenges that are particular to our region of Appalachia. Julia, do you want to take the first half and I can take the second?
Sure, yeah. So I think the very first thing that comes to mind always is barriers to access, right? Whether that be having to travel from a rural location to see a genetics provider or visit wait times. Shannon alluded to the fact that the cancer team has some pretty long wait times for their services. This has been improved somewhat through the availability of video visits. However, there are still some barriers to access even with video consults, right? the client needs to have some sort of phone or computer or tablet that's functional, that is up to date enough, that's a current software to be able to utilize the application. Has to be a smart device, right? They also have to have strong Wi-Fi, and so that the video and the audio connect, and as well as some level of technical literacy to be able to troubleshoot when things aren't going right. Especially if I think we've all encountered clients who maybe they're not hearing the audio because the audio output is set at headphones or something like that, and there aren't any headphones plugged into the device. And if there's no audio, our system actually doesn't have a chat function, unfortunately. So there's not much that we can do by way of troubleshooting without having to call them on their device potentially that they're trying to use for the video consult. So there are still some barriers there in places that can absolutely be improved. We've been working to establish more telemedicine clinics over time to try to get some clinics closer to where patients live. Like Shannon said, the cancer genetics program has hired some more genetic counselors, so has the prenatal genetics program. And with the cancer team, the on-call counselor is really helpful in getting patients seen in a timely manner when those results are urgent for their treatment and their medical care. For prenatal, the way that the clinic is set, they actually don't have very long wait times, which is good. Pregnancy doesn't stop. Everything is urgent in a pregnancy. So if something's truly urgent, we're able to get a patient in typically within 24 to 48 hours. Otherwise, a standard patient usually within a week.
Yeah. One other thing I'll say before moving on is that I think with the older age of the patient population in cancer genetics, the technical literacy and availability of something that allows you to do a video visit is probably more of a challenge than the typically younger population seen in prenatal. With financial barriers, so a lot of the people outside of the Pittsburgh metropolitan area are in more rural areas. There are costs associated with travel, and there are a lot of lower income areas in Western Pennsylvania. So when you couple low income with travel distance, it makes it harder to get to your visit. So we've already addressed some of the efforts through telemedicine and video visits to do that. One thing that helps more than you'd think are parking vouchers at Upmc McGee. I have had patients that are upset that they have to pay $5 to park. It's an extra cost on top of something that's already pretty high effort for them. One thing I mentioned before too is that there are perceptions that cancer genetic testing still costs $4,000 if it's not covered by your insurance, which used to be true decades ago. So we've really tried through our different efforts in community and outreach to say that's not quite the deal anymore. Please don't let the cost barrier be what prevents you from making an appointment and getting information to help you and your family. So we do have the ability to do price estimates. There are patient payment plans and out-of-pocket options. And many labs have pretty generous programs for patient assistance that are income-based that like a surprising number of people qualify for it. Something like if you're within 300% of the poverty line, your testing can be reduced or free. And many labs also have generous options for coverage for Medicare and Medicaid patients. So that covers all of the ground that we wanted to go over. We have our current contact information there. Just wanted to highlight again that even though this talk focuses on UPMC, my contact information is a little bit different now with NYU Langone. And unless, Julia, unless you have anything else to say, I think we can open it up for questions.
All right, I think folks have frozen on my screen. I'm not sure if you're able to hear me or not.
I can hear you, yes.
So my first question is, what are some of the opportunities you see for research to improve genetic service delivery in West Virginia and the Appalachian region?
Julie, would you like to go first?
Sure. Yeah. Some of the things I can think of off the top of my head, definitely research into awareness of genetic services within the area. Patients can't get to us if they or their providers don't know that our services are out there. So definitely some awareness. I would say research into alternative service delivery models is always, it's something that's actively ongoing in the field of genetic counseling. I think it's really important to think of additional ways that we can reach patients, whether that be through creating videos or group consults, maybe group information sessions and then individual one-on-one consults, but definitely research in regards to service delivery models could be really helpful.
I also, so there's a whole other conference that could be given on the issues surrounding genetic counselors not being Medicare, Medicaid recognized providers and how that limits our ability to deliver services. I would absolutely love to see someone retrospectively analyze data from the pandemic, which created this sort of setting where we were able to offer video visits. And what did that do? How did patients feel about it? Were people more able to comply with their visits because they could have a video visit even if their kid was sick or even if it was snowing, and I'm not joking, even if the sheep escaped from their field in Altoona? Like these are like things that some of our rural Pennsylvania population deals with. I would love to see some of the outcomes of that. I would be shocked if it was a net negative rather than a net positive. And I would love to see that used as justification to keep being able to offer these services. Because I think that, it's surprising the number of people that just the distance is too far. They have to drive to a McDonald's to get Wi-Fi, and any little bit that can help. The people that it's easy for them to come see us because they have a car and they live close by, I think are always going to come see us. But it's the people that are hardest to reach that we need to try and accommodate. So,
okay. I believe we have a comment or question from Dr. Caller.
Yeah, Kaler. Yeah, can you
Kaler?
hear me all right?
Kaler.
Yes. I do pediatric genetics, among other things, but also adults. And how do you interact with the pediatric genetics team and their metabolic services? And what do you do about people with PKU who live remotely who are 40 years old? And how does that all interface with the Pittsburgh Children's, I guess, genetics team?
Yeah.
Yes, so I can feel that one. I know the Children's Hospital has a general medical genetics clinic. They do also have a metabolic clinic, and they will see and follow patients through adulthood in that clinic. It's one of the few where they will follow patients into adulthood, and they do meet with those patients annually. Excuse me. The prenatal team and the pediatrics team are in contact a lot with these families. So if we prenatally identify a pregnancy that has an increased risk to have a metabolic condition such as PKU, we not only are we making sure that the neonatologists are aware, but we're making sure that the genetics team at Children's Hospital is aware, because they're going to be pulled into that baby's care soon after delivery. And vice versa. If they have a child who has been identified to have a metabolic disorder through newborn screening or something like that, and they're following that family, they'll then refer the family back to prenatal genetics to talk about risks in future pregnancies and options for future pregnancies.
Yeah, but that's a totally separate world, I guess, from what you've been talking about here today.
Yeah.
Places,
Unfortunately.
Cancer and prenatal genetics are usually some from the pediatric stuff, but the other business, like cardiomyopathies and that sort of thing, mitochondrial disorders of any age, they typically are going to be seen by an integrated service. There are very few places where there's a separate adult genetic service that's not staffed by people with pediatric training or experience. So anyhow, it's good to see this. Thank you.
Yeah. We got a couple of questions in the chat as well. The first one was commenting on the impact of the local genetic counseling training program on staffing. That one's fairly straightforward. Most of the people that have been hired in the past years have been new grads from the University of Pittsburgh Genetic Counseling Program. Not all. So I myself came from the University of Michigan, and I believe there's been at least 2 or 3 other new hires in recent years that are from sort of outside. But a lot of people do kind of want to stay in the Pittsburgh area afterwards. So it's probably like 50-50 overall. And then Julie, if you wanted to address the question from Dr. Fala.
And let me pull up the chat.
While you're doing that, I will just say that like the growth positions have been related to need rather than like the positions weren't created for like new grad students. If there were new grads that were applying to jobs that were created to address an existing need, then there were always applicants from the program, but it wasn't, we don't add positions that often that every new grad like gets a job.
But the ability to supervise students as they are going through their training program means that we do have to maintain a certain level of staffing to be able to do that. So the question was, do you think if the genetic counselor can work as independent providers and be able to independently bill, that could attract a genetic counselor to stay in clinics and decrease their attraction to industry? So I think this is a really thoughtful but really complex question.
Yeah.
There's been a lot of research within the genetic counseling community on reasons why genetic counselors leave the clinic space and go on into other opportunities. And one of the big reasons is burnout. Genetic counselors do a lot of work and we care a lot for our patients and tend to go above and beyond. There are not currently and probably will never be enough genetic counselors to be able to meet with patients and be utilizing the in-person service delivery models as we utilize them today. And so genetic counselors are stretched, oftentimes very thin in the clinic and seeing as many patients as they can. Some things that aid in genetic counselor or in reducing genetic counselor burnout are having the staffing to help with administrative work, so genetic counseling assistants or other scheduling assistants, billing specialists, authorization specialists, etc. I do think billing as an independent provider could be beneficial from a reimbursement perspective for hospitals and genetic teams. So in that regard, that could potentially then create funding for these other services to help with some of the administrative work. Yeah, I think that answers that question. Shannon, do you want to?
The only other comment I'll make that's related to burnout. So surprisingly, some people do have emotional burnout. You know, there are dealing with cancer risk, dealing with the risk to have a child with condition is all something that can take a toll on a counselor. But honestly, one of the most frustrating bits of burnout that also relates to things on a global scale is we spend so much time thinking about insurance coverage and price estimates. We had a weekly case conference on Mondays, and it was less what is the differential diagnosis for this patient and will this test be covered or not? A lot of G insurance counseling, to use a phrase from a couple of years ago. So national changes in what is covered and what is reimbursed, especially for repeated genetic testing when people have only had limited testing in the past. If counselors had to spend less of their time worrying about that, I think that would significantly reduce burnout. But that's another thing that would require national changes in the same way that national changes would be needed to recognition and credentialing. So.
I have a question related to that, and you can decide how personal you want to be. But you know, it seems like you both of you have made some career changes in the past few months, and you know, I've been my family is Appalachian, and you know, I've been in West Virginia for 12, 13 years now. And, you know, I don't practice as a genetic counselor, and the administrative burden played a big role in that for me. But can you, you know, help us as we try to retain great folks like you guys in the counseling profession in our region?
Yeah, I'm fine with talking about why. So my husband decided that he wanted to move to New York City. And that's how I ended up at the Pancreatic Center at NYU. It was nothing to do with the job itself. So hire people. This is a joke, but hire people who never want to get married. No, honestly, like UPMC was a great place to work, and it was just logistical things with my personal life that led me elsewhere. So Julia may be better poised to answer your question about retention, given that she just switched jobs within the same place.
Yeah.
Lost a faculty member in our department because her husband was in Connecticut, and you know it's hard to find you know, dual earning couples to find you know, jobs in our region and competitive jobs.
Yeah, I can say that when the position that I have now opened up, the thing that attracted me to the position, it was twofold. One was the ability to impact more patients. So through my position in the laboratory, I'm helping to generate reports. I'm helping that I participate in weekly discussions about our whole exome sequencing studies and what variants may or may not end up on a report, and is it related to a child's phenotype, and have opportunities to be involved in gene curation and development of new panels and such. And in developing a new panel, that's something that's going to be offered to many patients who I wouldn't have the opportunity to meet personally, but I know that what I'm doing is having a broader impact on the larger patient population. I help a lot with supporting the cancer genetics team here at McGee and the prenatal genetics team, especially as we offer more testing options for the prenatal team. So I still feel like I'm giving back to the patients in that way. It's just from a different lens. And I can say it was something that level of procedure and SOP is something that really fits well with my brain and my work style.
I will say, oh, go ahead, Julia.
Oh, I was just gonna say there have been other genetic counselors that have worked in this lab. I work with one other genetic counselor currently. And at the time that I was hired, there was not anybody here who had prenatal experience. So I really wanted to bring that lens into the clinic into the laboratory for thinking about future testing options from a prenatal perspective.
One other thought I have just related to retention and keeping people is that in about 2015 or 2016, there was a publication, I believe in the Journal of Genetic Counseling, about the creation of career ladders in specific genetic counseling clinics throughout the country. And at the time, it was a fairly uncommon thing, but that publication led to the development of career ladders in multiple places. So at all three of the institutions that I've worked at, a career ladder was either in place, actively implemented, or was about to be implemented in the near future. So giving people structure, giving people things to work toward, and then the knowledge that there will be some level of financial compensation when they reach those different levels is a good way to retain things, rather than just sort of like you're hired and who knows what will ever happen beyond this. And I think it's beneficial from a salary standpoint. But I know the career ladder at UPMC had things like if you published, if you gave a community lecture. So it helped professionally as well to establish connections with the place where you lived, which I think is also probably important for retention long term.
That's a good point. Yeah, and I don't know how widely those are implemented, but that is a good idea, and especially at our institution where we don't have as many genetic counselors to consider if in building a program, having those things in mind. Mm-hmm. But I know we're running late, and I appreciate you giving us your extra time and for a thoughtful conversation about genetic services in our region. And I don't see any other questions, so I'll thank you again for a wonderful presentation and a good discussion. And we look forward to following up with you in the future. And of course, our next session will be with NIMAC, with Alyssa Terry will be speaking to us, who I believe, Shannon, you will have probably more contact with going forward. But we look forward to seeing you all next month, and learning more about other ways that we can improve our genetic service delivery. So thank you so much, Shannon and Julia, for talking to us today. and
Thank
your
you as well.
presentation.
All right.
Thanks.
Thanks.
Thank you,
Bye.
everyone.
Bye.